So I think we're about to hear some themes, which I think is probably a good sign, right? You have three people to get up here and talk about similar related topics, and I think you're going to hear the same thing repeated for a third time. So I know I'm the last one of this session, but please don't fall asleep. Okay, so I have no conflicts to report. Some of the data that I will be presenting is new from my lab, and so it hasn't undergone peer review yet, so just an FYI, some of it is unpublished or currently in review. The objectives for today for me are to introduce ways in which sports medicine clinicians, so I'm an athletic trainer, I know I'm in a room with a lot of athletic trainers, so athletic trainers and physical therapists, what can we do from our perspective? How can we measure the psychological response to injury, and what is sort of within our control in terms of introducing a psychologically informed approach to rehabilitation? Then I'm going to describe the prevalence of these different psychological constructs in our athletes. Primarily, I'm going to be focusing on self-efficacy or confidence, fear or kinesiophobia, and then also pain catastrophizing. And then lastly, I'm going to explain the impact of that poor psychological response to injury on our clinical outcomes. So I'm a biomechanist, so I'm going to talk a little bit about the way our athletes move. I'm going to talk a little bit about muscle activity, a little bit about physical activity, and also pain and function. So as a clinician, Andrew did a really good job of talking about how we can look for clinical mental health diagnoses, right? But we know mental health is a huge umbrella, right? It's like saying physical health, right? It means so many things. And as a rehab clinician, there are constructs and behaviors and thoughts about pain that are detrimental to rehabilitation that we can measure in the clinic. So how can we do that? So these are the measures I'm going to be talking about that I just mentioned, and the first is pain catastrophizing. So pain catastrophizing is an exaggerated negative mental state brought to bear during, and this is the important part, actual or anticipated painful experiences. It is measured with a really simple patient-reported outcome tool. It's 13 questions. The patient reads each statement and then rates it on a scale from 0 to 4, 0 being not at all and 4 being all the time. The higher the score, the greater the pain catastrophizing. And this scale actually has 3 separate domains, including rumination. So this is when your athlete can't stop thinking about their injury, can't stop thinking about their pain, they ruminate on it. They magnify it, maybe blow it a little bit out of proportion. And then also they feel helpless in their ability to overcome, to return to sport, and they also may feel helpless in your ability to help them achieve their goals. One important thing I always like to note when I start talking about pain catastrophizing is a lot of clinicians sort of get this image of this athlete in their head of, yeah, they were blowing their injury or their pain way out of proportion, and I get that instinct as a clinician, but I just want to take a moment to remind everyone that our patient's pain is always whatever they say it is. Period. And we know that patients who catastrophize, they might actually be experiencing more pain. This isn't a pain neurophysiology lecture, but we know that the way we think about and view our pain can either turn up the dial on our pain or turn down the dial on our pain. So our patients who are catastrophizing and ruminating on their pain might actually be experiencing more pain than you would expect them to. Self-efficacy is sort of a synonym of confidence, right? So it's our patient's belief in their ability to do X, Y, or Z task. There are a lot of self-efficacy scales because it has to be task and situation specific. So, for example, I use the pain self-efficacy scale often, which is pictured here on the left of the screen. It is a 10-item survey where patients rate their confidence in their ability to do activities of daily living despite their current pain. There are also self-efficacy tools for physical activity, for home exercise programs, so you can gauge your athlete's confidence in their ability to do a wide variety of tasks. Kinesiophobia is just a really fancy word for fear of movement, fear of re-injury, and this is one that we see a lot in our athletes. The Tampa scale for kinesiophobia, which you can see here on the left, there's an 11-item version and a 17-item version. They are both valid and reliable and a very common tool that we use when measuring fear in our athletes. There are other scales, though, I will mention, that do measure things like fear avoidance or psychological readiness to return to sport. Lastly, I just wanted to mention well-being. So well-being is actually a positive psychological construct that we want to build in our athletes, similar to confidence or self-efficacy. It's something that we want to build up, and it can be potentially protective when they encounter challenging times like an injury. This is the 5-item well-being index from the World Health Organization, and it's just a general measure of your athlete's psychological well-being. So why do these factors matter? 2 primary reasons. One being scope of practice, right? As athletic trainers, as physical therapists, we need to have a robust referral network in place when we have athletes who are suffering with mental health challenges that fall outside of our scope, right? If we have an athlete who has depression or anxiety, we need to get them into the right hands of a mental health professional, a psychologist, a counselor, a social worker, whoever that may be. However, there's a lot within our scope that we can do. And so these different constructs of pain catastrophizing, self-efficacy, and kinesiophobia, these are areas that we can target through psychologically informed rehabilitation. We can help them to build their confidence through goal setting. We can help them to minimize their catastrophizing through mindfulness meditation. We can help them reduce their fear of movement through graded exposure therapy. And I know that Dr. Shelby Baez will be talking about some of these interventions later on this afternoon. But that's one of the whys, right? Because it's within our scope of practice. The second why is because we have found, and I'll show some data here in a second, that these constructs are actually more common than the mental health diagnoses in our athletes. So we know that more athletes will experience fear after an injury during the rehabilitation process at some point than will have clinical anxiety or depression, right? So they're important constructs to measure. So the measures that I just spoke about really are in this sort of feeling and thinking category of psychosocial health. The other important one that often gets lumped in when we say psychosocial instead of psychological is this social health, this relating piece, which is really important. And I believe someone touched a little bit on this earlier, and I will touch on it just briefly because it's not the primary focus of this. But social health, having social support is really important and critical in your athlete's rehabilitation. So if we take the psychosocial piece and we combine it with our traditional biomedical model, then we have the biopsychosocial model. And we know that the biological aspects of disease cannot and do not predict outcomes on their own, right? This has been shown time and time again with basically every orthopedic injury we can think of, that if we look at someone's osteoarthritis on an x-ray, or we look at the size of their rotator cuff tear, right? Those things don't directly correlate with how a patient will do, right? Worse imaging doesn't equal worse outcomes or worse pain or worse function. There's something else, and the something else is how patients think and feel about their pain and condition, and also the social support and other social determinants of health that are impacting that. So as clinicians, it's our primary goal and mission to adopt a more holistic approach to our patient care, and that means sort of living in the center of these 3 spheres. Each of these bubbles might be a different size for each individual patient, right? Some patients, you might have to really emphasize the psychology. They might really be struggling with a lot of fear, a lot of anxiety, a lot of rumination. Other patients, you might really have to focus on the biological side of things, right? They have a lot of arthrogenic muscle inhibition, or whatever it may be. So it really is individualized to that athlete. The other model that I think is really helpful for rehab clinicians in understanding how these psychological factors can impact the trajectory of rehabilitation is the fear avoidance model. And the fear avoidance model essentially suggests that things like pain catastrophizing and fear are some of the first predictors of how an athlete will do in terms of their long-term recovery. If an athlete has a painful experience, sustains an injury, and they are not very fearful, they have very low levels of catastrophizing, they are much more likely to head down the path of engaging with their rehabilitation and successfully returning to sport than disengaging with their rehabilitation and heading down the path of disuse and depression. So we already got some screening recommendations that were really, really good in terms of just broad mental health, anxiety and depression and other mental health disorders. In terms of these psychological constructs, what I think is helpful is when you're dealing with patients who have had pain for a long time. I'm a hip researcher, so I research intra-articular hip conditions and groin injuries, and most of the patients that I see and treat have had pain for years. And so in those individuals, I always assess their psychological health the first day I meet them because I know they've been in pain for a really long time, so I want to understand how they're feeling about that pain. In individuals with acute injuries, let's say an acute ACL tear or an acute ankle sprain, those athletes, we have to be a little bit careful. I'm going to show some data here in a minute. An emotional response after injury is normal and expected. So if you screen them the day after they tear their ACL, they're probably going to score as if they have really high pain catastrophizing and really high fear because that's what they're thinking about and focused on. But it will fluctuate over the course of their recovery. And so actually doing intermittent screening throughout rehabilitation is a better approach than just screening right after the injury occurred. And then for all individuals, all of your athletes, anyone, and I think everyone has said this so far, anyone who you suspect to be struggling with their mental health, definitely screen them. And then always, as an athletic trainer, physical therapist, sports med doc, before you return to sport. Because we know that high levels of fear and poor psychological readiness are associated with secondary injury and re-injury. Someone before mentioned expectations, and this is huge, right? And so this is sort of where you're starting to see the themes. But helping your athletes to set realistic expectations about what their rehabilitation will look like, all the way from you're going to encounter hurdles through you may or may not return to sport, right? Like here's the reality of what you're facing, and I think it's very useful for athletic trainers and physical therapists to help their athletes set realistic goals throughout the rehab process because, all athletes get hurt and they're like, sure, oh, you guys can see my pointer. Surely my, recovery will be smooth. This awful thing happened. I'm going to work really hard. I'm going to return to sport as soon as possible. It's going to be seamless. And as sports medicine clinicians, we know that's never true, right? There will be a hurdle. It will be different for every athlete, but there will be. And so setting realistic expectations is important. Okay, so prevalence of poor psychological health in our athletes. So this is a study, it's not published yet, it will be under review soon, but we looked at, I'm showing here two different surveys, self-efficacy and well-being. So we looked at their confidence relative to their ability to perform their sport during practice and confidence in their ability to perform their sport during competition. And this was in Power 5 Division I female gymnasts. And we had them fill out this survey from day one of preseason all the way through postseason play. So we had about 28, 29 weeks of data, and they filled it out these specific surveys every other week. And what I'd like to highlight first here is that all of these are scored on a scale from 0 to 100, 100 being the best, the most confident, and the best well-being, right? Showing up at preseason day one, we are in the 70 to 80 range, right? So we can already make improvements in their confidence and in their well-being the day they step foot in the gym. So that's an important takeaway. The second is the blue and orange lines are the confidence measures. And you can see that there's this divot around time point 7. And interestingly, about 40% of the injuries that occurred throughout the entire season occurred within 2 weeks of that fluctuation. Now, I certainly can't say that's causative because the study design was not set up to do so, but it is an interesting finding. Additionally, I want to highlight these little drops in well-being. And these we could explain with midterms and finals. So we saw that their well-being, right, no one's surprised right now, their well-being dropped at midterms and finals. And this tells us as sports medicine clinicians, this might be an opportunity for me to provide more support to my athletes in times when they're having, additional external stressors, maybe school. So we know that, the response to injury is always going to be highly individual, and that fluctuations in the response to injury and the psychological response to injury will fluctuate over time, just like we expect pain and function to fluctuate over time. So this was a study we published a few years ago looking at pain catastrophizing and pain following ACL injury. So the first time point is within 10 days of tearing their ACL. So you can see in the solid black line, their pain catastrophizing scores are pretty high, right? Their pain is also pretty high. This is what we would expect. They just tore their ACL. Of course, they're thinking about it all the time. They're ruminating on it. It's the biggest thing that's happened to them recently. Of course, we expect their attention to be there. Then, if we look at day of surgery, both have dramatically decreased, right? Because they've probably done some prehab with their athletic trainer or physical therapist. The swelling starts to go down. They can start to walk with maybe a normal gait again. They're feeling a little bit better about it. They have a plan. They're going to come back. And so they're emotionally feeling better as well as physically feeling better. Then we look 2 weeks following surgery and we see another spike, right? And this is to be expected. 2 weeks after surgery, they can barely make a quadricep muscle. They can, their gait is all wonky. They're maybe not allowed to be weight bearing depending on what procedures they had done. So we see a spike in their catastrophizing, we see a spike in their pain. And then subsequently at 6 weeks and 6 months, we see both decrease. So the take-home message here is be cautious. An emotional response after injury or joint trauma is expected and is not necessarily indicative of a poor outcome. So back in the world that I usually work in patients with chronic hip conditions, we found that across the board in all of the studies that we've done, over 50% of the patients that walk through the doors of our hip preservation clinic had either high pain catastrophizing, low confidence, or high levels of fear. That was greater than what we saw when we looked at who had a diagnosed mental health disorder, which was still high, about 1 in 3 of them. We know there's a relationship between anxiety, depression, and chronic pain. That's a talk for another day. But we found that these other psychological constructs may actually be more sensitive to negative injury-related thoughts and emotions that can give us some information and something to sort of sink our teeth into in rehabilitation. These pie charts demonstrate the difference between patients with ACL injuries on the day of surgery and patients with chronic hip pain when they present to the hip preservation clinic. And you can see that the patients who have really high levels of pain catastrophizing are highlighted in red. So, the relationship between duration of symptoms and psychological response is a little bit murky, and I don't know if I want to completely go down that rabbit hole. This may suggest that if your patient's been in pain for a really long time, it's worth asking them about their mental health. Okay, so hopefully I've convinced you we should screen people and that it's pretty common that athletes have a negative psychological response following injury. Now the question is, okay, well, what is the impact, right? What does it matter? It does. So first I'm going to go over the impact of poor psychological health on patient-reported outcome measures. So this would be, I ask my athlete, how is your pain, how is your function on a patient-reported outcome scale? And so this was patients with hip or groin pain, and we had them fill out the pain catastrophizing scale, the pain self-efficacy scale, and the kinesiophobia scale, and then also ask them about their hip function with a tool called the IHOT-12. And what we found was that there was a moderate to strong relationship between confidence or self-efficacy in hip function, as well as kinesiophobia or fear in hip function, in such that patients who had stronger levels of self-efficacy, so higher confidence, reported that they were more functional. And patients who reported lower levels of fear reported that they were more functional, which is pretty common sense, but the data support that. Interestingly, sort of circling Andrew's talk in with mine, we found that in patients who had depression or anxiety, they reported higher levels of pain catastrophizing, higher levels of kinesiophobia, and lower levels of confidence. So not surprising, but it appears that there might be this sort of cumulative effect, right? That perhaps being anxious at baseline makes you catastrophize more, or being depressed at baseline makes you ruminate more. So there is something to that. Then we followed folks after surgery. So they all had hip arthroscopy, and we followed them afterwards. And what we found here was that The odds of having elevated pain after surgery, we looked 3 months after surgery because that's sort of a critical moment in rehabilitation when patients are becoming much more functional following hip arthroscopy. And the odds that they still reported elevated hip pain 3 months after surgery were 45 times higher if they had low confidence heading into surgery. And they were 4.5 times higher if they catastrophized before surgery. In terms of function, the odds that they reported poor hip function following surgery were 14 times higher if they catastrophized prior to surgery, and 7.5 times higher if they had high levels of fear heading into surgery. For some patients, the poor psychological response that we see preoperatively, it carries through postoperatively. So it is a sustained response, or it doesn't seem to get better. Kinesiophobia specifically is what we looked at here, that persisted postoperatively in some patients. And then those patients who had persistent fear of movement, they were much more likely to report poor hip function following surgery. Okay, so that's patient-reported outcome measures. What about how people move, right? This is sort of our bread and butter as sports medicine clinicians, athletic trainers, physical therapists. We can help you move better, right? That's one of the best sort of tools that we have in our tool belt. In terms of movement quality, I'm going to start with some data on knee injuries. The first is patellofemoral pain, so anterior knee pain. And some researchers found that in patients who had higher levels of fear, they descended stairs with less knee flexion, meaning they were kind of adopting a stiffer descent strategy. And then in individuals who are post-ACL reconstruction, they landed from a drop vertical jump, which is more of an athletic maneuver, in a stiffer position, so including less knee flexion, less hip flexion, and less trunk flexion. What we found in our lab in patients with hip injuries is very similar. So we found relationships between pain catastrophizing and kinesiophobia and hip flexion, peak hip flexion angles, only when we looked at very demanding single leg tasks. So if we looked at something like walking gait, which isn't a very demanding task, nothing really shakes out. But when we put them just on their injured limb and we asked them to do a more demanding task, like a single leg squat or a forward step down, then we started to see these relationships emerge. And so during a single leg squat, we found that individuals who reported higher levels of fear, they went through less hip flexion range of motion. They had lower peak hip flexion angles. When we had them do a forward step down task, which is a little bit of a different task, it's sort of a repetitive motion, those that had higher pain catastrophizing scores also went through less hip flexion range of motion, so they had lower peak hip flexion angles. Just to back up for 1 second, this is really important clinically, right? Because as a clinician, if I'm just working on movement retraining, or I'm just trying to figure out what muscles are weak so that you can move better, or I'm just trying to figure out, a strategy for you to not drop into dynamic knee valgus, right? Those are all good things to do and definitely within our wheelhouse. But if we're not also addressing the fear or the catastrophizing, we're sort of missing the boat, right? It has to be an and situation. We have to address the movement and the psychological response to injury. So in this particular study, we wanted to actually look at muscle activation. So we used surface EMG electrodes, and we put them on the anterior chain and the posterior chain. So we did rectus femoris and glute max, and then we had them do a double leg squat task. So they did 5 squats in a row. And we looked at the activation of those muscles during the entire squat task. And what we found was that patients who had higher fear of movement, so higher kinesiophobia, they had lower activity in their glute max and their rectus femoris. This is also important clinically, right? Because muscle activation is something that we can target clinically, and we can also target fear of movement clinically. So again, it's an and situation. We need to be targeting both. So that's movement quality. In terms of movement quantity, how much are people moving? And this, is important for our athletes throughout their lifespan, right? We need people to remain physically active even when they're done being a competitive athlete. So the top article is from Dr. Shelby Baez, who you'll hear from this afternoon. She found that self-reported knee confidence or self-efficacy and quality of life accounted for over a quarter of the variance in the number of steps folks took daily following ACL injury. And then we found something very similar. So the bottom scatter plot is from our recent study that's in review, and we found that a patient's confidence and their ability to be physically active was related with how physically active they were. It's not shocking, but it's an important clinical finding. So if patients were more confident, they had a higher moderate to vigorous physical activity. All right, so in terms of return to sport, the vast majority of this literature is really in ACL, ACL reconstruction. And what we know is that, again, this is Dr. Baez's work, individuals with high levels of fear or kinesiophobia were 17% less likely to return to sport following ACL reconstruction than those with lower levels of kinesiophobia. And self-efficacy is really sort of shaking out as a really important factor to rehabilitation compliance and adherence. And so self-efficacy was predictive not only of rehab compliance, but also return to sport following ACLR in this article. There's not as much done in the land of the hip. We're probably 20 to 30 years behind where we are in the knee right now. But there is one study that demonstrates that fear is one of the most common reasons that individuals don't return to sport following hip arthroscopy. The last outcome measure we're going to look at is re-injury, and this is sort of a developing field, but we do know that kinesiophobia, high levels of kinesiophobia and or poor psychological readiness are associated with re-injury, and this work is mostly done, again, in ACL reconstruction. So that can either be an ipsilateral tear, so a re-injury, or a contralateral tear on the other side. So this is where I was just going to touch on the social aspect, because obviously this is very important. We talked about culture this morning, so we're going to circle it all back together, because there's a really interesting relationship between social interactions and pain. And so there's been some basic science studies that have basically taken individuals, just healthy individuals, and they did what's called a cold pressor test. So they put their hand in a bucket of ice water and they asked them to rate their pain. And then they did it again and asked them to recount a painful emotional experience. So social isolation, bullying, these types of experiences. And found that when they were recounting these experiences like bullying, they had worse pain. And this is consistent with what we see in other literature showing that bullying, which we talked about this morning as one sort of red flag for culture in all of sports, really, and also loneliness, which we really struggled through with the pandemic, are associated not only with increased levels of pain and the development of chronic pain, but also athlete burnout. So team culture matters. The last thing I'll touch on is mental health literacy. So it's great that everybody's here, and I'm so glad that we're starting to have these conversations, because clinicians who have a better understanding of the consequences of poor mental health on injury outcomes and just athlete well-being are not only more confident to help their athletes, but they also have fewer stigmatizing beliefs and attitudes regarding mental health just in general. So in summary, hopefully you walk away with these sort of points in your mind. One, psychological health can be easily measured and tracked over time to see if whatever interventions you're trying are making any difference. Two, that poor psychological health is common following musculoskeletal injury, and that psychological health will fluctuate throughout the course of rehabilitation, and this can be very normal. And also that the responses will be highly individual. And then lastly, that poor psychological health is associated with worse clinical outcomes, no matter how you spin it, right? It can be pain, patient-reported function, how people are moving biomechanically, how they're activating their muscles, how much they're moving, their return to sport, right? The list goes on and on and on. So definitely associated with worse clinical outcomes. Last slide, I promise, some practical tips, and I know we're going to go through this afternoon, but establishing rapport, this really doesn't ever seem to be a problem in my experience in sports medicine. Athletic trainers spend so much time with their athletes that they're really good at building rapport. Engaging in active listening, making sure our athletes feel heard and seen, providing resources and education in whatever way that athlete will best receive that information. Developing an action plan. This is another thing that we've heard a lot about today. So make sure you're proactively screening. Make sure you have a policy and procedure. Make sure you have an emergency action plan. Also, an evidence-based treatment protocol. We're going to go over treatments this afternoon. And also a really robust referral network. Lastly, just really work on, I'm sure everyone here already does this, destigmatizing mental health in your athletic training clinic, because that can go a long way. These are my funding sources. Thank you for your time.